and we use all of it all the time for something. We talk about functionality being divided into the limbic system and the reticular formation. The limbic system is basically our emotional brain. There's structures, especially in the medial aspects of the cerebral hemispheres, the diencephalon, a lot around the brain stem. And if you look here, you can see you have your cingulate gyrus, olfactory bulb, hippocampus, amygdala, hippocampus, amygdala, cingulate gyrus, olfactory, all these areas are involved, hypothalamus as well, with the limbic system of the brain. It's the emotional, also called affective aspect. The amygdala is for recognizing angry or fearful facial expressions. It says danger, elicit fear response. And the cingulate gyrus expresses emotions via gestures and helps you resolve mental conflict. Now, you all know when you were a kid, your mother could say something to you, and she could say, "Hello, Johnny, you're a nice young man." And she'd say that with a happy look, and you'd feel happy if you happened to be Johnny. She could say it with an extremely angry look on her face, and you'd be running because you knew you were going to get a whipping. So we can definitely read facial expressions and know whether we're in trouble. Also, the limbic system is also has odors are very much involved, and we know that we have an emotional response to smells, like good smells, bad smells, and make a difference in whether we like someone or not. But also interacts with the prefrontal lobes, and we can emotionally understand things that we consciously know are happening. The hippocampus and the amygdala also play a role in memory. Now, the reticular formation involves the nuclei, raphe nuclei, medial and lateral nuclei, and it's a little bit silly term to me, far-flung axonal connections. Hypothalamus, thalamus, cerebral cortex, cerebellum, spinal cord. Basically, physically, the reticular formation involves your brain, and it sends out signals to the cerebral cortex to keep it conscious and alert, filters out weak and repetitive stimuli. If you have complete severe injury to the reticular activating system, then you'll be unconscious or in a coma. The reticular activating system is important for motion as well. Coarse limb movements, also has visceral autonomic functions. And this is showing far-flung radiations, but you will take a note, everything is going through the thalamus. Visual impulses are coming through the lateral geniculate bodies of the thalamus and then going back here to the visual center. But everything through your brain comes and goes through the thalamus. An electroencephalogram measures electrical potentials between various areas of the cerebral cortex. And this is showing a boy up. This is no doubt outdated, but to get his brainwave activity recorded. And just very much like an electroencephalogram is recording the electrical activity of the brain, the electrocardiogram, the electroencephalogram is recording the neuronal activity. And everybody has unique brain waves, and we have alpha waves that you're just chilling out. Beta waves you're mentally alert. Theta are irregular, more common in children. Delta waves, high amplitude, this is like in sleep. Here we have alpha, beta, theta, and you are zonked out here asleep. Now, The electroencephalogram, the purpose is to help localize lesions, tumors, infarcts, abscesses, especially to try to pick up epileptic lesions. Now, the chance of actually having an epileptic event while you're hooked up to the EEG machine is probably remote, but it does happen. Another thing that the EEG is used for is to decide whether a person is brain dead or not. If you have a flatlined EEG and you know it was done right and it's done by more than one person and more than one machine, you can say that person is dead, even if they have reflex responses. It would just be spinal cord responses. But a flat EEG is death. Epilepsy, and when they're talking about here, they're talking about tonic-clonic seizures, lose consciousness, fall stiffly, uncontrollable jerking. About 1% of the population. Does not mean the person has any intellectual impairments unless they have brain damage from lack of respiration. During these seizures, they may develop problems. Absent seizures or petit mal seizures. These are most common in young children, but it does happen in adults. They just go blank and they miss a few moments of time and then they come back. And it's important with teachers, especially of young children, that they're trained to recognize the difference in a kid not paying attention and one that actually has blanked out. Tonic-clonic or grand mal seizures. The victim loses consciousness, bones are broken, they may defecate and urinate on themselves and bite their tongue. And you're not supposed to restrain a person when they're having grand mal seizures. You're supposed to just lay them on their side and try to keep them from hitting their head. They will die from respiratory failure because you can't breathe while you're seizuring. So if it goes long enough, untreated seizures are fatal. One that's not mentioned in the book is a psychomotor seizure. And this is generally secondary to drugs. I think the guys who are eating people's faces after taking the so-called bath salt drug, that's got to be an example. They're completely unaware of what they're doing. They're physically moving and they can't control their actions. I've seen this in a dog that had a drug reaction, and he tore everything up in the room he was in and was going to kill anyone who was around him. Drug wore off, he was perfectly fine. Okay, there are anticonvulsive drugs, vagus nerve stimulators, surgeries. The CBD oil is the new latest and greatest anti-seizure drug going. Consciousness, perception of sensation, being able to voluntarily initiate movement, control it. This is higher mental processing. Loss of consciousness, fainting, or syncope is a signal that something's gone wrong with the brain. We have stages of consciousness: alertness, drowsiness, stupor, and coma. In coma, someone cannot be awake. Now, sleep is partial unconsciousness, but you can arouse the person. And the brain has two steps: non-rapid eye movement and rapid eye movement of sleep. The start in sleep, you generally start with non-rapid eye movement, and fourth stage sleep about 90 minutes in, and then rapid eye movement sleep starts abruptly. But the eyes move. Theoretically, most of the body is paralyzed. Now, you may have seen someone, I'm very amused watching my dog take a nap and sleeping and dreaming. They'll be vocalizing and chasing things. I don't know if it's squirrels or rabbits. They don't mention it, but you definitely see that rapid eye movement sleep. This is an EEG when someone's awake. Rapid eye movement, very much the same. Skeletal muscles are inhibited except for ocular muscles and diaphragm, unless they're not. They could be moving chasing rabbits. Okay, non-rapid eye movement, you have a sleep, it's just beginning, alpha waves, you can still arouse them easily. Stage 2, a deeper sleep. Stage 3, much deeper sleep. Vital signs are decreasing. Stage 4, very, very deep sleep. You can't easily wake the person out of this stage of sleep. This is when your bedwetting, night terrors, and sleepwalking occur, which surprises me because I would have thought they occur during rapid eye movement sleep. Sleepwalking is actually quite dangerous. You can walk out into the traffic. A circadian rhythm is a natural 24-hour rhythm, and we should have cycles of sleep where we get up at the same time each morning, we go to bed at the same time, and have 8 hours more or less of sleep. If the reticular activating system is inhibited, it is inhibited, but also mediates dreaming sleep. And sleep patterns, we've already talked about, go between non-REM and REM sleep. Here's a chart showing you that. Sleep is very important. The non-rapid eye movement is for restoration of your body. Allow it to just rest and heal, restore enzymes, put neurotransmitters back where they were, and just get things to where you feel better. Rapid eye movement sleep is also very important. If you're deprived of rapid eye movement sleep, you become moody and depressed. You can't think as sharply. And worst case scenario, if it goes on long enough, you actually can go completely psychotic and die. What good it does is not completely known, but it has to do with memory, forming memories. So before you take your test, you should get a good night's sleep or you're going to forget everything that goes on. This I don't think I agree with. The older I get, the more I like to sleep. But they say the requirements decline with sleep. Sleep orders, narcolepsy, lapsing into sleep from the awake stage. This is very inconvenient if one is driving a vehicle because you can kill yourself and others. Insomnia, inability to get to sleep or to stay asleep. Now, sleep apnea is a temporary cessation of breathing during sleep. This is more common in younger people, and it does increase the chance of heart attack, stroke, high blood pressure, and death in general. Okay, language. We have basal nuclei involved in language, and the Broca's area and the Wernicke's area. These are on the left side of the brain, and then on the right side, the corresponding areas are for nonverbal language components. Broca's area is actually making thinking through what you're going to say and making the words. If someone has a stroke in the Wernicke's area, they may still be able to speak beautifully. It's just that what they say is nonsensical. Okay, memory, we have 2 stages. Short-term memory or working memory, it holds 7 to 8 pieces of information, and then long-term memory, which has limitless capacity. So, outside stimuli, whatever it is, sometimes we just automatically remember something because it was interesting and we just thought of it. Some things are put into short-term memory. To transfer them into long-term memory, it depends on the stage of excitement, rehearsal. That's where you get out your Quizlets, read, study, association of old and new data, the little jingles you make up to memorize a group of information. Now, even from the long-term memory, sometimes you can't find where you put it, so you can't retrieve it. Short-term memory, if it's not transferred to long-term memory, you're going to lose that memory. I've already mentioned these. Declarative memory is factual knowledge. Explicit information. What is your name? What day is it? Has related to conscious thoughts and language, and it's stored in the long-term memory in the context in which it was learned. So if you see a person out of the context in which you know them, you may have a difficult time pulling up their name. Non-declarative memory is stuff you do. Riding a bicycle, for instance, very hard to unlearn. If you know how to ride a bicycle, you know how to ride a bicycle. Now, brain structures in declarative memory, the hippocampus, surrounding temporal lobes, acetylcholine from the basal forebrain is necessary for memory formation and memory retrieval. So, people who have memory disorders, Alzheimer's or vascular dementia, they are treated with acetylcholinesterase inhibitors, making more acetylcholine available, and it greatly improve their memory. It's not curative, but it does treat the symptoms and can be a lifesaver for people. Let them work a few more years till they get to their retirement. Let them just enjoy life or keep their independence a little longer. And this is showing the basal forebrain acetylcholine. Okay, brain structures involved in non-declarative memory. Motor memory, cerebellum. Emotional memory is amygdala. Now, procedural memory, you have to have basal nuclei, inputs from the thalamus, cortex, and dopamine substantia nigra. There we have our procedural skill memory circuits. Now, the molecular basis of learning, we know we have physical changes that take place. We know that neurotransmitters are released. We know that new synapses are formed. Calcium, enzymes are involved. In reality, the actual formation, the chemistry of memory is nobody knows. Now, protection of the brain, skull, meninges, cerebrospinal fluid, and blood-brain barrier. The meninges cover and protect the central nervous system, protect the blood vessels, enclose venous sinuses, and they contain cerebrospinal fluid and also form partitions in the brain. We have arachnoid mater, dura mater, arachnoid mater, and pia mater. Okay, the dura mater is the outermost layer right here, and it's very tough, and most of you remember from lab, it's extremely tough stuff, very protective. The strongest, and it also forms separations in the brain. Arachnoid mater, that means spidery mother. And this is where you have your cerebrospinal fluid, blood vessels, arachnoid villi protrude into the superior sagittal sinus and permit cerebrospinal fluid resorption. Okay, and there's the superior sagittal sinus, and should be an arachnoid villi. Pia mater is very delicate vascularized tissue that clings to the brain, and if you have a dissection sample, peeling it off is no thicker than a sun you peel off your skin. Cerebrospinal fluid, watery, less proteins and ions than a plasma has, and you should have a constant volume. Gives buoyancy and protection from trauma to the central nervous system. Also has nourishment and contains chemical signals for the central nervous system. Now this picture shows you number one up here in your ventricles. Choroid plexus of the ventricles produces the cerebrospinal fluid, and it moves to all these areas around here, around the brain. Here it's resorbed, all the way around here through the central canal of the spinal cord, around the spinal cord. And this fluid is equivalent to this fluid, so you can actually take a sample from the subarachnoid space in the spinal cord and get a good idea clinically of what is going on in a brain that's malfunctioning. The choroid plexus produces cerebrospinal fluid at a constant rate, kind of from each ventricle, and you have clustered capillaries enclosed by pia mater and a layer of ependymal cells. The ependymal cells actually use ion pumps to control the composition of the cerebral spinal fluid and help remove wastes. But the blood-brain barrier creates a stable environment for the brain, separates the neuron from many blood-borne substances. Some things go through it and some do not. And it's because of the tight junctions in the endothelium of capillary walls, as well as basal laminae and then the astrocytes further create tight junctions. So only certain things can go through and get into the brain. It's a very selective barrier. And nutrients can move through, such as glucose, fat-soluble substances such as alcohol, nicotine, and anesthetics go past the blood-brain barrier and actually cause reaction. Some areas, like the vomiting center and the hypothalamus, you don't have a blood-brain barrier, and that's essential because if you do have a blood-brain barrier there, your hypothalamus is not notified that you have toxins in your bloodstream. And if you do have toxins in your bloodstream and it came from something you eat, you really need to vomit it out and get rid of it. Okay, homeostatic imbalances of the brain, traumatic brain injuries, concussion, you get hit in the head, you pass out or get dizzy. It's a very minor temporary alteration in brain function. However, concussions are additive. They add up and can cause permanent damage. Contusions. A contusion can happen at once or it can be from an additive effect of concussions. Now, subdural or subarachnoid hemorrhage, there's nowhere for that hemorrhage to go, and it bleeds, and without surgical intervention, it's going to push and crunch and kill large parts of the brain, and worst case scenario, the brain stem may be forced through the foramen magnum, and then you're dead. Cerebral edema follows a concussion or contusion that's severe enough, any kind of traumatic head injury. And the same thing can happen. You get enough edema, and without medical intervention and a whole lot of good luck, you have the brain stem forced through the foramen magnum and you get dead. Now, cerebrovascular accidents, also known as strokes. Circulation is blocked. You have a clot, an artery, or a brain. Now, you have hemiplegia or sensory deficits on the contralateral side of the stroke. Transient ischemic attacks are temporary, reversible cerebral edema. Tissue plasminogen activator is the only approved treatment for stroke. Now, before giving this, you need to know this is an ischemic stroke, because clinically, you can't tell whether you have a stroke or you have a bleed. If you had an aneurysm and the blood pressure got high enough that this aneurysm ruptured, then you can have a brain bleed. So you really need to know, you need to diagnostically assess this patient, preferably with an MRI before doing anything. So terrible, tremendous emergency, because the longer this goes on, the more brain damage you have. Okay, Alzheimer's disease. Note the lack of a T. There's no need whatsoever in arguing with the general public. They all call it Alzheimer's, but that's not the correct pronunciation. It's a progressive brain disease. I've heard it said, if it doesn't kill you, you didn't have it. The only absolute definitive diagnosis is autopsy or possibly a brain biopsy. You have to have the neurofibrillary tangles and plaques in the brain, and generally comes with age. Parkinson's disease is degeneration of the dopamine-releasing neurons of the substantia nigra. Huntington's disease, formerly known as Huntington's chorea, is a fatal hereditary disorder. It's an autosomal dominant and you get basal nuclei degeneration and degeneration of the cerebral cortex, and the person has abnormal movements, and then eventually they die. The reason that it's not been taken out of the gene pool is because the symptoms usually start after childbearing age. Okay, spinal cord starts at the foramen magnum and ends at the coda medullaris at L1 vertebrae. It provides two-way communication to and from the brain, and spinal reflex centers are in the spinal cord. The same basic protection, bone, meninges, cerebrospinal fluid. You also have a cushion of fat, and cerebrospinal fluid is again in the subarachnoid space like it is in the skull. This is showing someone beyond the actual spinal cord, down deeper into the cauda equina area, taking a tapping off to get cerebrospinal fluid, and probably for diagnostics. Okay, now the spinal cord has cervical enlargement, thoracic spinal nerves coming off, lumbar enlargement, and then right in here, cone medullaris. And beyond that, you have the cauda equina, and it ends in the filum terminale. 31 spinal nerves, cervical and lumbar enlargements, and the nerves in the upper and lower limbs come from the cervical for the upper and lumbar for the lower limbs. And the cauda equina is just a collection of nerve roots at the inferior end of the vertebral canal. Cross-section anatomy, let's just look at the picture here. We have here our fat pad. This is obviously dorsal. And here's our white matter. And then this butterfly-shaped section is your gray matter. You have a ventral canal right here. This is your dorsal horn, ventral horn, lateral horn. Dorsal is sensory, as is the dorsal root ganglia. Ventral is motor, and here's your neuron, goes here. Lateral is only going to be in the thoracic vertebrae, thoracic spinal cord, because this is actually sympathetic nervous system, gray matter. The white matter is your myelinated tracts, taking messages up and down the spinal cord and across the spinal cord. Okay, and this is basically the same picture. Dorsal horns, sensory. Ventral horns, motor. Lateral horns, only in thoracic, and a little bit of the lumbar, sympathetic neurons. The dorsal root ganglia, again, dorsal, sensory. And as you see also, some interneurons are still in the dorsal horn. White matter, ascending and descending tracts, commissural fibers, and we call these, they're in funiculi on each side. Okay, we have pathways some that decussate, some consist of 2 or 3 neurons, and always the pathways are paired symmetrically on each side of the spinal cord or brain. Now, this is clinically relevant. Okay, types of neurons, upper motor neurons, we're talking about pyramidal cells, we're talking about primary motor cortex, aka brain. Lower motor neurons, we're talking about the ventral horn motor neurons of the spinal cord. They specifically innervate skeletal muscles. Now, if you have spinal cord trauma, you may get sensory loss or you may get paralysis. A flaccid paralysis is from damage to the ventral root or ventral horn of the spinal cord. No impulses get there. There's no voluntary, no involuntary muscle. So you get a flaccid paralysis. Just think about, floppy, flaccid. You pinch the legs all day and they're not going to move because they can't move. Even if there's sensation, they cannot move. There is no movement. Now, if you have upper motor neuron damage, so you're getting brain damage, you still can have sensory function. I mean, you still can have motion. I'm sorry, I said that wrong. You can still have motion, movement, reflex movement, but the brain is not involved, so there's no voluntary control. If one transects the spinal cord, quadriplegia transected in the cervical region. If it's high enough in the cervical region, you also cease to breathe. Paraplegia, transection somewhere between T1 and L1. And once they're transected, they're transected. Poliomyelitis is a viral disease that is causes ventral horn motor neurons destroyed, and it causes muscle atrophy. Death tends to be due to respiratory muscle arresting, and survivors of polio may develop post-polio syndrome years later. All I want to say is vaccinate your kids. You don't want your kids becoming paralyzed because you didn't give them a vaccine. Amyotrophic lateral sclerosis, this is the one you cure by pouring buckets of ice water on your head. It involves progressive destructions of ventral motor neurons and fibers of the pyramidal tract. Individuals lose the ability to speak, swallow, and eventually breathe, tend to die within 5 years of diagnosis or of symptoms that may not be diagnosed immediately, but of symptoms occurring. And they may still have full cognition, know exactly what's going on, but they can't speak, swallow, and then eventually breathe. The cause is generally not known. There's several things listed here as unknown. The central nervous system is established within the first month of embryonic development. Gender-specific areas in brain and spinal cord develop depending on the presence or absence of fetal testosterone, regardless of the political correctness of it. Girls are different than boys. There's no way around it. They're just different. One's not bigger, one's not smarter, one's not dumber. They're just different. Without that massive amount of fetal testosterone, they would not develop their external genitalia. Now, radiation, drugs, alcohol, opiates can hurt the developing central nervous system. Smoking can cause low birth weights. It can also specifically cause neuron death in the fetal brain. And you can have stillbirths or small birth weights. And the general problem is vasoconstriction. The baby just doesn't get enough blood and enough oxygen. Okay, the hypothalamus is one of the last areas in the central nervous system to develop. In the visual cortex, neuromuscular coordination develops from a superior to inferior and proximal to distal direction along myelination. Think about a baby can wave his arms around long before he can walk. Age brings cognitive declines, but many people have full cognition well up into their 80s, some as far as 100. Environment and genetics affect this. If you have a large alcohol consumption, it's been proven to cause cognitive decline. Other drugs cause cognitive decline. High blood pressure and numerous mini strokes can cause it. Any kind of vascular problems, the same thing that causes heart attacks can cause dementia. Probably the main reason that we have more dementia patients than ever before is because people are living longer. Now, I want to say one thing in review on damage to the spinal cord or brain. If the brain is damaged, you still can have movement because the spinal cord is intact, so you still get reflex responses. If the spinal cord is destroyed, you get no movement at all. And this is something that confuses some families of patients. They say their child's not brain dead when actually they are. Okay, that's all for now.